everyone. I pray all of dental colleagues around the globe, Megagen and Minak family are all fine and healthy. This catastrophic pandemic did not stop Megagen from innovation. I'm very glad to move forward and present this online lecture. I strongly believe that we human beings are strong and we will overcome this situation soon, and our world will become more united and we will live in peace and harmony. During lockdown, a lot of my patients were eager to be treated by me, and it was an awakening experience. I never realized how meaningful this profession was. Dentistry is not some elective procedures, but it is an essential one in sustaining our daily life. Dentistry is absolutely necessary and important profession, and dental colleagues play an important role in our society. With this important notion in mind, I would like to present about facilitation of full mouth reconstruction using the innovative technologies of R2GATE, R2 Studio CBCT, and micro CT scan. Dr. J.C. Kim, the creator of R2GATE, described R2GATE in this page. R2GATE is composed of two parts, restorative and surgical planning softwares. So what is R2GATE digital oral design software? It is a computer program of fundamental prosthodontics. Basically, by using this program, you will become a top-notch prosthodontist regardless of your specialty. I believe this is the most important advanced dental diagnostic and treatment planning software in terms of prosthodontic and implantology. Software alone is not enough. We also need powerful hardwares. R2 Studio is one of the most advanced digital diagnostic and restorative equipment you can find. It has various functions, but the most representative ones are large FOB CBCT, whose size is 20 by 20 millimeters, and it has built-in 3D facial scanner to digitize the head of the patient, and it has an impression CT scan which can digitize almost any dental object. It is extremely versatile machine, and it complements R2GATE software very well. Let's think about full mouth reconstruction. It's regarded as one of the most challenging tasks in dentistry. It's not about filling a cavity or restoring a tooth. It's about creating and restoring the most important digestive organ. A lot of dentists love or fear this procedure for various reasons. Some people like it because they think it's lucrative, and some people avoid it because they think it's risky. And you have to think about a lot of things such as aesthetic, phonetic, video, and prosthetics. These are the three examples of a full mouth reconstruction cases. Fully implant bone prosthesis on the upper and the lower arch on the left, and complete denture over complete denture in the middle, and implant bone prosthesis opposing a complete denture on the right. Let me first share a full arch, not a full mouth case, but full arch case that I did 20 years ago. This was one of my first extensive case that I did right after I opened my private practice. I placed 8 implants on the maxilla, and this was the restoration. At that time, I felt that this restoration was okay. The midline was off a little bit. The color pink porcelain was not looking very natural. And I tried to believe that I did a decent job. But this patient happened to be very picky, and she was not very happy with the result. She expressed the concern that the arch form was not symmetric, and she could feel the canting of the anterior teeth. While she was right, I was trying to justify myself and trying to believe that she had unreasonably high expectation. The funny thing was that she expressed her disappointment during 20 years of recall, but she had a very good manner and pleasant personality. She referred me a lot of patients too. Every time I convinced her that the result could have been better if I did the whole mouth, not just one arch. After 20 years, her mandibular teeth gradually deteriorated and needed extraction and implants. She was eager to go through full mouth reconstruction this time, and she wanted perfect teeth with perfect alignment this time. I know she had a hefty standard and high expectation. Am I falling into a trap here? Should I be hesitant? Should I convince the patient to lower her expectation? With a great armamentarium such as R2GATE, R2 Studio, and micro CT scan, and great support and backup from my laboratory, I promised her that I could meet her expectation this time. First thing first, I need to digitize her head inside and out. I used a radio-opaque impression tray to take an impression. While the tray and the impression was locked in place in her mouth, I took the 20 by 20 field of view CT scan. The radio-opaque impression tray was clearly visible in the scan. Then I took the impression CT scan and digitized the impression. I can obtain the whole digital information of the impression in STL format, and also I can extract the teeth information like this. First, I need to do the matching of the radio-opaque tray in the CT scan with the STL file. Then extract just the teeth information like this. Then I can easily position the upper and lower models with a pinpoint accuracy. CBCT orientation is toward the machine when the patient was standing inside CBCT gantry. Therefore, the orientation of CBCT does not have any meaning. Now, I need to reorient this CT scan data toward dentofacially meaningful planes, and that's called CBCT reorientation. First, I try to find mid-sagittal plane like this, and horizontal plane. I find campus plane and position the occlusal table in mid-sagittal and campus plane. It looks like this, and now I can find out what went wrong 20 years ago. I can instantly see that the occlusal plane was not even on one side, and midline and symmetry was very off. Then I quickly ran cephalometric analysis program in R2GATE just to look at the occlusal plane and the maxillary information. Her maxilla was neutral, not prognathic or retrognathic, and central incisor angle was slightly proclined. Occlusal plane angle in relation to Frankfurt horizontal plane was good, and it should be around 8 degrees, and it was. Now I have a reorientation done, and I have a proper midline, and the best midline derived from skeletal and facial midline. I know the ideal occlusal plane, curve of Spee, and curve of Wilson. I made a virtual wax-up of the maxilla, and this ideal wax-up was completely independent, unrelated to the existing lower teeth, which will be extracted afterwards. What's important here is to come up with the most ideal upper design, and I easily came up with it through R2GATE program. I can position the upper implant model inside this 3D facial scan and her CBCT data here. Here is the 8 implant that I placed 20 years ago, and they're still fine. Scan bodies were connected and digitalized, and based on the virtual wax-up that I did, my technician designed and fabricated custom abutment and provisional bridge. When you look at the design of the upper bridge, it's completely unrelated to the lower dentition because all her lower teeth will be removed and restored from scratch. As you can see from this picture, the upper provisional restoration was ideally done. It is aligned in perfectly proper midline and campus plane. Ideal symmetry was achieved, and it is simply aesthetically pleasing to look at. The upper bridge was simply replaced with a final full zirconia bridge, and the lower implant procedure was done, and here is the final outcome. I was very satisfied with the result, and patient was thrilled to have this treatment. I was able to correct the 20 years of disappointment and resentment and make this patient very happy. Virtual 3D wax-up on the left seems to be very closely resembling the final outcome on the right. When we do full mouth reconstruction, we are working as a creator, and we have to look at things in multiple perspectives. We are not creating smile on piece of paper. Therefore, I do not really support the idea of two-dimensional DST concept. We have to have this notion of three-dimensional concept. In 3 dimensions, we have 3 axes. In human body, when you spread your arm widely, that is x-axis. Y-axis is parallel to the long axis of your body vertically, and your z-axis is projecting to the front of your body. When your head rotates in x-axis, there is a nodding motion, or I call it yes motion. When your head rotates in y-axis, your head shake, or I call it no motion. When your head rotates in z-axis, it will make side to side tilting of your head, like this. In determining the midline and occlusal plane, we have been using these primitive tools like floss, ruler, and fox plane. We have dentofacial analyzer from various companies, and these seem like an improved method, but still we have to rely on our visual perception, which can be easily distorted. I got this slide from JC Kim. This is a great demonstration of how our visual perception can be distorted and inaccurate. For example, this is a Raptor 22 stealth fighter jet, and when we look at the frontal view, it looks very symmetrical. But when I place the grid like this, we can notice that the left wing is lower than the right wing. If I put a mirror image like this, now it is in perfect symmetry. When we try to find the midline, we cannot just rely on our visual perception with floors, ruler, or dentofacial analyzer. We have to be careful. Moreover, skeletal midline and facial midline do not always coincide. Actually, they usually deviate from one another. It's a tricky business. With large FOB CBCT and 3D facial scanner, we can come up with the most proper midline through the process called CBCT reorientation. We have many literatures about how to find proper midline. In Facial Aesthetic Journal, Farhad Naini argued that the upper facial third, the orbital area, are relatively symmetric and stable. The maxilla and mandible always receive compression and torsion, and their bone gradually remodel and become asymmetric over years. But the orbital area is likely to retain original symmetry, and that's what we want to use to find the skeletal midline. We first superimpose right and left orbital area and determine the skeletal midline. Then we come up with the best compromise between skeletal and facial midline. Then we rearrange CBCT in Frankfurt horizontal plane and save the data. This process is called CBCT reorientation. I think it is a profound concept. Then we want to utilize large FOB CBCT data to perform 3D ceph analysis. People usually get intimidated by ceph analysis because we don't use this method very often in our private practice other than orthodontists. But for the purpose of prosthodontics, it is very simple and easy to use, and it is extremely useful tool as well. And all of you can learn this cephalometric analysis in less than 5 minutes, I believe. We can evaluate VDO using these three values. The central incisor angle and position can be estimated using these two values. In full mouth reconstruction, we don't use angles classification. When there are no teeth, angles classification cannot be used. Instead, we use McNamara analysis to find maxilla and mandible position in relation to base skull. The Frankfurt mandibular angle is shown here, and its normal value, its average value is about 22 degrees. Occlusal plane angle in relation to Frankfurt horizontal plane is about 8 degrees. And if a patient show physiologic video, this 8-degree plane is roughly parallel to campus plane. I use campus plane, or some people call it a la tragus line, and it is the go-to plane for building the occlusion. Y-axis is a growth plane in adolescent, and it represents VDO in adults. It starts from sella to Nathan. Its angle from Frankfurt horizontal plane is about 60 degrees on average. If it is somewhat less than 60, then it may indicate loss in vertical dimension. We do not want to deviate from this value too much. Maxillary central incisor to SN is about 106 degrees, and it can indicate degree of proclination. Nasion perpendicular line or McNamara line is a very evaluating maxilla and mandible prognathism or retrognatism. Usually A point is in line with the nasal perpendicular line. In this case, maxillary A point is about 5.6 millimeter in front of nasal perpendicular line, and it indicates maxillary prognathism. Pogonion is usually 3 millimeter behind the nasal perpendicular line. A point McNamara line gives us guidance in where to place central incisor. It has to be placed 4 to 6 millimeter in front of A point McNamara line. When you actually do 3D Ceph analysis in R2GATE, you will be very surprised because it's very intuitive and easy to use program. Although it's not an absolute indicator, 3D Ceph analysis provide enough insight and information, and I believe it is an indispensable tool in undertaking extensive restorative cases or aesthetic challenges. Occlusal canting. In undertaking full mouth reconstruction, we have to be very careful about midline and symmetry, occlusal plane, and three-dimensional position and angulation of anterior teeth. In other words, occlusal canting. Occlusal canting may occur in all XYZ axes. Let me demonstrate it here with a virtual wax-up and 3D facial scan. Here the patient's face is reoriented and it is aligned with the proper midline and horizontal plane. And the wax-up was done accordingly. So it has normal occlusion and symmetry. When there is a Z-axis canting happens, the whole wax-up was rotated in Z-axis and it shows canting like this. And it is very easily noticeable because the difference is very prominent here. Y-axis canting is very subtle and we can notice it easily from the top view here. Same thing with the X-axis canting. It is very subtle and it can be noticed easily from the side view. Arch shape and symmetry is also extremely important when doing full mouth reconstruction. Sometimes it poses a great challenge if previously placed implant is not within normal position. Here in my case, the patient had a mandibular implant placed by another dentist in the past, and I tried to make symmetry as much as possible, but it was not very successful here. Here are the several steps in R2GATE DoD software. First, we do positioning of a study model on the CT scan file. Then we align the 3D facial scan into CT scan. Then we do the reorientation. Next step is Ceph analysis. Then we do the digital oral design. We first do the preliminary design of maxillary anterior teeth using 3D facial scan and existing study model. Then the next step is an easy wax up. Here you can do full mouth wax up and it's very easy to do it yourself. It is only a diagnostic wax up and it cannot be used as an actual restoration. But this wax up enables us to communicate with the technician 100%. We can export this completed wax up and go back to DoD stage and load the wax up with a 3D facial scan. It is a very powerful tool both in terms of diagnosis, planning, and patient presentation. Almost all the patient gets highly impressed by the technology and properness. Based on diagnostic wax-up, surgical planning can be done and guide can be fabricated. Let me demonstrate each step with this case of mine. Basically, this patient needs extraction of all her teeth and immediate denture and implant treatment upper and lower later on. The patient shows very proclined maxillary anterior teeth. I first took the 20 by 20 field of view large CBCT with a 3D facial scan. First, study models were matched and positioned with pinpoint accuracy. Excuse me. Right now, this CBCT is not in proper alignment with mid-sagittal plane and Frankfurt horizontal plane. Through simple reorientation procedure, which takes about a couple of minutes, I can reorient it in proper alignment. And here we go. We can see the picture on the right. The superimposition of the right and left orbital area was done. Midline was determined. Horizontal plane was found. Now CBCT is in alignment with these planes. The data is saved, and this blue line represents midline. Every time when I turn on this case, it will be in this alignment, and it is a very convenient feature. Then I do 3D Ceph analysis. The first value that I look at is a y-axis value, and it is 60.9 degrees. It indicates that the patient did maintain VDO even if patient's posterior teeth were collapsed. FMA value was about 23 and it's close to 22. Again, it indicates that the VDO was maintained. Occlusal plane angle in relation to Frankfurt horizontal plane was 8 degrees, and her existing occlusal plane was proper, and it should be used, not altered. After McNamara analysis, I found that her maxilla was about 5.6 millimeter prognatic, and her mandible showed very slight prognatism. This means with a little effort, I can create beautiful smile for her and provide life-changing reconstruction. Then I placed 20-inch Monson sphere occlusal plane in line with her existing occlusal plane, and it's roughly parallel to her campus plane. The occlusal plane was positioned to the intended labial surface of the central incisor, and it shows curve of Spee and curve of Wilson and the midline. 3D facial scan was placed into CBCT, and now the patient's whole head is digitalized inside and out. Now we have her facial information, her bone information, and her teeth information. From her 3D facial scan, her teeth portion was removed. Now I'm doing preliminary digital oral design of maxillary anterior teeth. With this occlusal plane as a reference, I quickly designed her maxillary anterior teeth, and it can be loaded with 3D facial scan here. Then I go to the next step. From study model, all the teeth were virtually extracted, and then the preliminary DOD wax-up was loaded on the model. Based on this information, full arch wax-up was done on the maxillary model, and the mandibular wax-up was completed. This wax-up STL file was sent to my technician to design the immediate full dentures, and the full wax-up was brought back to DOD stage and loaded on 3D facial scan so that the wax-up can be evaluated 3 three-dimensionally on the whole face. It looked very decent and aesthetically pleasing. My technician can use my wax up to design the immediate full denture. When comparing the wax up to the existing teeth, the maxillary anterior teeth moved lingually about 4 millimeters. However, with the immediate denture, moving anterior teeth lingually pose great challenge in making dentures because of denture flange thickness. So the denture teeth had to be moved to the front about 2.5 millimeters in this case. Anyway, here is the finished denture with a very nice result. All her existing teeth were extracted and the immediate denture was delivered. She wore this denture for a couple of months and her gingival tissue healed and her alveolar bone remodeled a little bit. PVS wash impression was made with her denture and they were digitized with impression CT scan, which comes with R2 Studio CT scan. The denture STL file was used to print this radiopaque denture containing barium sulfate. With these dentures in her mouth, another CBCT scan was made. Matching was done easily and precisely with the radiopaque denture, and now we have her oral mucosa information. And another diagnostic wax-up was done. Excuse me. And it was loaded into 3D facial scan. 3D Ceph analysis was done to evaluate the final wax-up, and everything looked so good. And based on prosthodontic planning, ideal implant planning followed automatically. I spent about a total of 2 hours to come up with this stage. Considering the extensive treatment the patient has to go through, and considering the financial compensation that will be generated, 2 hours of computer work was not that much. And I am absolutely sure that this whole process in full agreement with the fundamental prosthodontics, and I believe it is very the best plan that I can give to the patient. I know it is a bold statement, but it is true. And I'm very proud to be able to use R2GATE and R2 Studio comfortably and proficiently. Let me end my presentation with this last full mouth case that I did last year. This patient had very poor implant plate treatment, and all of them needed to be removed. Patient showed roller coaster occlusion and severe canting in all XYZ axes were evident, and arch form was very asymmetric. To make matters worse, this patient wanted to start and finish the treatment on the maxilla first. Then he wanted to finish the lower jaw later. This posed a great challenges. First, his provisional dentures were digitized with impression CT scan. Radio-opaque denture containing barium sulfate was 3D printed. The denture, bite registration, and the stone model were all digitized with impression CT scan. Here is the STL file of upper denture and lower model. Matching and positioning of the denture and lower model were done with pinpoint accuracy. 3D facial scan was matched and positioned onto the CBCT data, and now I have a fully digitized patient head inside and out. The lower model showed a symmetry, canting, and roller coaster occlusal plane. I wanted the upper wax up to be completely independent from the lower dentition, but my technician was not familiar with the concept of independent wax up. From technician's perspective, the upper teeth need to be related to the lower teeth. My technician's wax up was rejected by me this time. Again, the second wax up was rejected by me again because it was still occluding with the lower teeth. Completely independent upper teeth is a new concept for any technician, and I decided to do the virtual wax up by myself for the first time here. The new R2GATE program came out last year with this feature, and I was not very familiar with this easy wax up program. Anyway, I used the occlusal plane and made this upper wax up with a very satisfactory result. It looks good now. As you can see, my upper wax up is not in alignment with lower teeth, which will be extracted later on. The 3D Ceph analysis was completed and evaluation of the wax up showed the favorable result. And based on the virtual wax up that I did, my technician completed the design of the provisional bridge that I intended to deliver immediately after the surgery. Then, based on the prosthetic design, implant planning was completed, the surgical guide was placed. Up until this time, I did the flapless surgeries, but I do less and less flapless surgery now, and more regular open flap surgery because I prefer visible surgery, not blind surgery. Nonetheless, all 8 implants were placed as planned and multi-unit abutments were connected. Temporary cylinders were connected and provisional bridge was connected to the temporary cylinder, and provisional bridge was connected to the temporary cylinder like this. And when you compare the surgical program, surgical planning to the actual surgery result, it closely resembles each other. Upper PMMA provisional restoration was completed after the surgery, and patient used it for a couple of months. After all the implant healed well, scan bodies were connected and impressions were made. Wait a moment here. Scan body and impression? Why not intraoral scanner? When we talk about digitization tool in dentistry, we think of intraoral scanner. It's becoming increasingly popular dental device. And I was huge fan of intraoral scanner for a long time. I started with CEREC 10 years ago, and later on I got iTero, and now I use 3Shape Trios 3. 100% of my small span cases are all done using intraoral scanner. Why not long span case? When it comes to intraoral scanners, scientific literatures are not very supportive of this device, and none of 2019 articles that I found support the use of intraoral scanners for long span cases for several reasons. They are not accurate. The precision and trueness is inferior. And when it comes to full arch or full mouth scanning, the scan distorts a lot. And when there is more than 5 teeth missing in the edentulous space, scanner should not be used. As you can see from these diagrams, When the pontic space becomes longer, we must not use intraoral scanner. Because if you do, you will end up having this kind of a distortion, and the result will be open margin or ill-fitting prosthesis. For extensive restorative case, I use micro CT scanner. Basically, micro CT scan has exactly same feature as clinical CBCT. The difference is that it uses much higher kVp and its sensor has much higher resolution. In dentistry, micro CT scan has been used for research purpose only. Micro CT as a dental restorative device was first recognized by Dr. Sang-Chul Lee, the CEO of a Ray Corporation in Korea, and he is a very close friend of mine. In 2017, Dr. Baek Seung-hoon and Seoul National University published an article about micro CT as a potential dental object scanner, and they published in Nature Journal. They micro CT scanned the impression of this typodon and analyzed the accuracy. And it was concluded that the micro CT scan data was far more accurate than intraoral scan method. Then how do I digitalize full arch case? I use micro CT scanner. For full arch case like this, I first take polyether impression on the implant arch and PVS impression on the opposing arch and use micro CT scan to scan the data. And the scan data is sent to the dental software like 3Shape to design the prosthesis. This is an 8 implant supported one-piece screw retained bridge. This case cannot be done with an intraoral scanner. Regardless of what kind of intraoral scanner you use, your scanner cannot handle this kind of a case. Intraoral scanner as of 2020 are not accurate enough for long span screw retained bridge. The upper restoration was done very nicely. The lower should be done very easily because I can just follow the ideal upper. The existing implants and the healing abutments were utilized here. First, impression was made using radio-opaque impression tray. With this impression tray in the mouth, CBCT was taken. Model scan data were extracted and matched and positioned into CT scan with pinpoint accuracy. Now I have a precisely positioned model information inside CT scan information. Everything here is easy. Virtual wax-up was done in no time and implant planning was followed. Here, the surgical guide was supported by the healing abutment on the existing implants. All 8 implants were placed and existing implants were all removed. Healing abutment was placed and patient went back home and came back the next day. And this time, rather than utilizing multi-unit abutment and temporary cylinder to make a provisional bridge, I decided to directly make implant level impression over the scan body. By registration and implant level impression and opposing arch impression were all scanned using micro CT scan. And the scan data was fed into 3Shape design software to come up with the design of 7 titanium custom abutments and 13 unit bridge. The whole procedure was expedited in 3 days. Patient did not have lower teeth for 4 days after the surgery, and he did not really mind it, and I was very lucky. 7 titanium custom abutments were connected, and provisional bridge was cemented with temp bond. There was one implant that did not have enough primary stability for immediate loading, and I needed time for osseointegration. After 3 months, the bridge was simply replaced with the final one, and the last implant was restored as well. It was a very challenging case in the beginning because existing poorly restored lower bridge posed great challenge. With the great support and guidance from R2GATE and R2 Studio and micro CT scan, the case was done very well, and it was completed with happy ending. Let me summarize the whole presentation here. For full mouth reconstruction, we have to consider all these factors carefully. Midline, occlusal canting, arch form and symmetry, VDO, aesthetic, and occlusal scheme have to be all considered carefully. And if you use and follow all the steps in R2GATE digital oral design software, all the important factors that I mentioned will be taken care of completely. For full arch, long span cases, it always distort like this, and we must not use intraoral scanner for full arch case like this. Impression CT scan feature built into R2 Studio is a very handy tool. You can digitize the impression, model, and denture. And for final restoration, I have to use micro CT scanner to digitalize the rubber impression, and it is the most accurate digital data that we can obtain. This is the end of my presentation. Please contact me without any hesitation if you have any question or comments. And if you practice in US, please send us your implant case to R2 Digital Laboratory, and I believe we have the best quality for all your implant needs at very competitive pricing. Thank you so much. Stay safe and healthy, everyone.